Hello everyone. I think we are live. Hello and good evening to everyone. I hope my audio and video is good, right? Yes, let's get started. This will be the recall session of the FMGE JAN 2025 medicine questions. We'll discuss the medicine questions asked and I'll help you come to the right answer as well. Let us start with the discussion part. Okay. First question. A patient presented with unilateral throbbing headache, photophobia, nausea and vomiting. Symptoms improved after taking sumatriptan. What is the likely diagnosis? So when you have got a unilateral headache on one side, okay, with associated features like photophobia, nausea, vomiting, this is more suggestive of migraine. It is not tension type of headache. Why? Because tension type headache has a bilateral type of headache in the frontal region, just like a band of tightness around the forehead. So that is not the answer. And cluster headache will be having associated features like autonomic symptoms, ipsilateral redness of eyes, ipsilateral watering from eyes, ipsilateral watering from nose. None of the autonomic symptoms are mentioned, hence that is not the answer. Regarding subarachnoid hemorrhage, again, we do not have the typical history of a thunderclap headache, not mentioned. And also the symptoms improving after taking sumatriptan. Patients with subarachnoid hemorrhage, the headache is not going to improve with use of sumatriptan. And we know that the sumatriptan is the drug of choice for the treatment of an acute episode of severe migraine. So the answer for this question will be option B, migraine. Let's go to the next question quickly. A patient reports a viral infection 3 weeks ago. Please take a special note, viral infection 3 weeks ago. And what is the current symptom? Ascending bilateral symmetric flaccid weakness and absent deep tendon reflexes. No bowel or bladder symptoms. What is the most likely diagnosis? So when you have a preceding viral infection and following that there is a neurological illness, one important disease that you have to consider is GBS, that is Guillain-Barré Syndrome. And are the features suggestive of GBS? What do you think? The patient is having LMN weakness or UMN weakness, upper motor neuron type of weakness or lower motor neuron type of weakness. Look at this, it is flaccid weakness. So flaccid weakness means what? UMN weakness or LMN weakness? LMN weakness, right? And we know that in Guillain-Barré syndrome, you can have absent deep tendon reflexes. And the description is the typical pattern of GBS, that of the ascending type of weakness, which starts in the lower limb and subsequently may involve the upper limbs, right? So what about the bladder and bowel symptoms? Are they common or uncommon in GBS? They are relatively uncommon. So this feature is also again suggestive of the Guillain-Barré syndrome. So the answer for this question is Guillain-Barré syndrome. So for my students who are having doubt, sir, why not multiple sclerosis, sir? See, multiple sclerosis produces UMN weakness or LMN weakness. What do you think? It is UMN weakness. So that is not correct. And in multiple sclerosis, you will have prominent bowel and bladder symptoms. In amyotrophic lateral sclerosis, again, this will present with a mix of UMN and LMN findings. But remember, it will not have this sort of a symmetrical presentation because amyotrophic lateral sclerosis has asymmetric presentation. That is what you have got to understand, and it will not produce the typical bilateral symmetric ascending type of weakness. What about transverse myelitis? Remember, transverse myelitis is an important differential diagnosis of Guillain-Barré syndrome. So in transverse myelitis, Can the patient have UMN weakness or LMN weakness? It is UMN weakness. But remember, even in transverse myelitis, in the stage of neuronal shock, the patient can have some sort of flaccid weakness. So how to differentiate Guillain-Barré syndrome, which is an LMN disorder, versus a transverse myelitis, which in the initial stage of neuronal shock may present with flaccid weakness. Yes, later it becomes the spastic weakness, but initially it may have a flaccid weakness. So how to differentiate? Remember, transverse myelitis will have prominent bowel and bladder symptoms. So that is also not correct, because here bowel and bladder symptoms will be positive. Okay. So what is the answer for this question? Guillain-Barré syndrome. Okay, clear. Coming to the next question. Again, very important topic is that of meningitis. So remember, for FMG exams, bacterial meningitis, tubercular meningitis, viral meningitis, all are important topics. So here, patient presents with headache, vomiting, and also neck stiffness. The CSF is showing a turbid CSF. So what have I told you? Turbid CSF is more suggestive of what type of meningitis? Bacterial meningitis. And what are the findings in CSF? 90% neutrophils. So when you get a neutrophil predominant pleocytosis, are you thinking about bacterial, tubercular, or viral? It is bacterial. What about the glucose? The normal CSF glucose level is 50 to 80 milligram per deciliter. What about this patient? There is a decrease in the glucose levels, right? And what is the protein? 200. What is the normal protein levels? It comes to about 15 to 45 milligram per deciliter. So protein level is also elevated. So all the features are suggestive of that of an acute bacterial meningitis. And what is the question? What is the most appropriate empirical management? What do you think? In case of an acute bacterial meningitis, usually the causative organisms are the pneumococcus as well as Neisseria meningitidis. So in a patient of the typical adult age group, the empirical antibiotic therapy is ceftriaxone plus vancomycin. What about the use of vancomycin? Is it for MRSA or something else? What do you think? Well, I know that most of you are familiar that vancomycin is very useful for MRSA, but in this particular context, please understand that the use of vancomycin is for attacking the pneumococci that are resistant to beta-lactam antibiotics. That is why you are giving vancomycin in this case. Acyclovir is given in viral meningitis only. Ampicillin in cases of Listeria meningitis. So I am not considering other options. The option that is going to be the answer is option B, ceftriaxone plus vancomycin. So in the comment section, yes, I can see Dr. Ranjit, Arvind. Yeah, all of you are saying the right answer. Right. Let us go to the next question. And what do you think is the answer for this? A patient presented with weakness of the right half of face with deviation of angle of mouth to the left side. Okay. So there is some sort of a facial muscle weakness. Okay. Now, he is also not able to close the eyes completely on the right side as shown in image. So you can very well observe that yes, there is a deviation of angle of mouth to the left side. You can also see that on the left side, the nasolabial fold is prominent, but on the right side, the nasolabial fold is not prominent. Correct? And also just compare the eye closure on the left side versus that of the right side. In the left side, the patient is completely able to close the eyelids tightly. A tight buried eye closure is possible. But in case of the right eye, you can see that only a partial eye closure is possible. Okay. And this is going to tell me that the weakness is not confined to the right lower half of face, but it is involving the upper half of face as well. So there is a weakness involving the entire side of the right side of face. So what do you think? Well, I have told you, when you think about a weakness in one side of the face totally, it is not going to be a UMN palsy. It is not going to be a supranuclear palsy. So I'm already eliminating the options which are containing supranuclear, right? Now, is it either a nuclear or infranuclear problem? Anyway, in the option, there is no nuclear problem, which means the facial nucleus is not affected. So this could be a problem in the nerve. Now, what do you think? Which side is affected? Okay, it is the right side that is affected, right? The right side facial muscles are weak. So hence, what is going to be the answer? There is a palsy, weakness involving either the nuclear or the infranuclear part on the right side, which is why my answer is going to be option C, right? Okay. Next question. 28-year-old man brought to the emergency department after road traffic accident. On examination, he is confused, opened his eyes to speech, and localizes pain when a painful stimulus is applied. What is his Glasgow Coma scale? Very important question for FMG exam is GCS score. Very, very important, very frequently asked. Can you guys tell me what is the GCS score? So he is actually confused. Okay. So you look at this. This is the GCS score. Confused. It is 4. And then opens his eyes to speech. Opens his eyes to speech, which is 3. And then localizes pain, which is going to be 5. So 4 plus 3 plus 5, it is going to be 12. So what is going to be the answer for this question? It is option D. Okay. It is option D. It is going to be 12. Okay. Right. So let us go to the next question. 40-year-old HIV positive patient with a CD4 count of 45. So what does that mean? HIV patient with low CD4 count. And low CD4 count means when you get such a question in FMG exam with a low CD4 count, it always means that the patient is at risk of developing opportunistic infection. So the patient has developed headache, fever, and neck stiffness, right? So maybe we are considering a meningitis here. So what sort of meningitis could this be? Let us look at the CSF analysis. It shows multiple oval yeast cells surrounded by a clear halo on India ink preparation. So when you hear this term, India ink staining, especially meningitis occurring in an immunocompromised patient, what are you thinking about? Yes, as Dr. Arvind Chintu has rightly said in the comment section, we are thinking about a diagnosis of cryptococcal neoformans causing a cryptococcal meningitis. And that is the typical diagnosis here for this question, right? Okay, let us go to the next question. Elderly man underwent prosthetic valve replacement a few weeks ago. So the patient has undergone a prosthetic valve replacement recently. And the question is, what is the most likely causative organism of his current infective endocarditis? Is it Staphylococcus aureus, coagulase negative Staph aureus, Enterococcus fecalis, or Streptococcus viridans? What do you think is the causative organism? Well, I have shown you this in my routine lectures as well as the revision video, QRP videos in the DocTutorials app about this chart showing us summary of all the important causative agents of the infective endocarditis. Here the question is about prosthetic valve endocarditis. I have told you that there are two types of prosthetic valve endocarditis. One is early occurring and the other is late occurring. Early is within 1 year after prosthetic valve replacement and late is after 1 year of prosthetic valve replacement. What do you think has happened here? This is early prosthetic valve endocarditis. So you are thinking about coagulase negative Staph, and hence the answer is going to be option B, coagulase negative Staph. If it was, a late, because this one specifically says few weeks ago. If it was a late event, yes, then the answer would have been different and you can consider Streptococcus viridans. But here the question specifically is underwent prosthetic valve replacement just a few weeks ago, right? Very, very important. And I want all my children to be very thorough with this particular chart that I have shown you. And can somebody tell me what is the example of a coagulase negative Staph? It is Staph epidermidis. It is staph epidermidis. It is staph epidermidis, right? Okay, that is clear. Coming to the next one, again, cardiology this time had good number of questions for the FMG exam. Let us see this question. Graham-Steell murmur, very important question, my dear students. The next few questions that I am discussing are the most important questions. Why? Because the FMG exam, one of the most important system is cardiology. So even students who are following the DocTutorials app, I always tell them, if you are short of time, at least watch the revision videos of cardiology. Very short summary videos, few minutes, 5 minutes, 6 minutes, short videos are there. So question is, Graham-Steell murmur is associated with, what do you think is the answer? My dear children, can I tell you 5 golden points about Graham-Steell murmur? 5 golden points about Graham-Steell murmur. Number 1, it is an early diastolic murmur. Number 2, it is a high-pitched murmur. Number 3, it is a decrescento configuration. That is the intensity of the murmur from diastole will show a slow decrease in intensity. Okay, that is called a decrescento type of murmur. And it is best heard in the second left intercostal space close to the sternum. And the intensity of this murmur increases with inspiration. And what is the condition in which you get Graham-Steell murmur? It is pulmonary regurgitation. Pulmonary regurgitation is the condition where you get Graham-Steell murmur. And my dear students, this is an ultra high yield table which I have taught you in my DocTutorial lectures. Ultra high yield table on the various type of murmurs and associated conditions. Systolic murmur, diastolic murmur, continuous murmur. Okay, so what are the examples you have to know? In this particular question, it is regarding the early diastolic murmur. There are 2 important causes of early diastolic murmur. One is aortic regurgitation, the other is pulmonary regurgitation. This entire table is very important. This time they asked about early diastolic murmur. Next time they may ask about mid diastolic murmur. So this table ultra important for FMG exams. Okay, right. Now coming to the next question. Severe mitral stenosis is indicated by. Severe mitral stenosis, what do you think? Soft S1? No, it is wrong. We know that as the severity of mitral stenosis increases, usually the S1 becomes loud. Usually S1 becomes loud as the severity of MS increases. But does all severe MS have loud S1? No. Can you tell me what is the exception? In which scenario can a patient have a severe MS but still a soft S1? Remember, in patients who may undergo calcification of the mitral valve leaflet, you may still get a soft S1 in a severe mitral stenosis. Important point. Okay. So anyway, option 1 is ruled out. Presence of S3, well, S3 is indicative of some problem with the left ventricle, or even you can have a RVS3 in problems with right ventricle, but that is not going to be the answer here, because in MS, it is not that chamber which is predominantly getting affected. Presence of opening snap. So opening snap, we know the forced opening of the mitral valve can result in opening snap. But can you say that just because opening snap is there, mitral stenosis is very severe? You do not have a direct association like that. No, you cannot say like that, because again, calcification can influence the opening snap. In degenerated calcified valves, you may not get a prominent opening snap. Now, next point is very important. I have taught you in my lectures is about the A2-OS gap. A2 is the part of the second heart sound. So decrease in A2-OS gap. So what have I taught you in my routine lectures? So in my routine lectures, so one doubt by Vasif, but opening snap is present in MS. Vasif, I agree that opening snap is present in MS. But what is the question, Dr. Vasif? It is severe MS. So when do you say MS is severe? Okay, MS is said to be severe when there is a decrease in the A2-OS gap. So if you remember the cardiac cycle which I have taught you in my lectures, so after the closure of the second heart sound, that is where the S2 is, and then when there is an opening snap, because after the isovolumetric relaxation phase is when the valve will open. So when there is a lot of pressure inside the left ventricle, what is going to happen to this A2OS gap? The gap between the second heart sound and the opening snap, it will narrow down because the mitral valve will open very quickly in case of a patient having severe MS. So opening snap occurs early in severe MS. Opening snap occurs late in mild MS. Okay, so this is the right answer, option D. Right? Okay. Let us go to the next question. Female patient presented with palpitations and dizziness with a BP of 80-60 mmHg. So the patient is having some sort of palpitation and dizziness. Maybe it could be an arrhythmia. Anyway, the patient is in hypotension. Now, what could be the reason for this? Look at this. Absent P waves with irregular RR interval. What diagnosis am I thinking about? Atrial fibrillation. I am thinking about a diagnosis of atrial fibrillation. Okay. Question is, what is the next step in the management? So atrial fibrillation management, well, any sort of these arrhythmias, tachyarrhythmias, where the patient is hemodynamically unstable, what do you think is the answer? Okay, what do you think is the answer? The answer is going to be cardioversion. Very good. So you have correctly answered as cardioversion in the comment section. Now, my dear children, very, very important point I am going to tell you. How did I understand this patient is hemodynamically unstable? Remember, hemodynamically unstable patient, you have to give shock, okay, cardioversion. But what are the important signs of hemodynamic instability? Number one, hypotension, which the patient is having. Number two, acutely altered mental status. What could be the reason? Because when there is a decrease in cardiac output, in such patients, there is a reduction in the cerebral perfusion. The blood supply to the brain is reduced. So that can cause altered mental status. Signs of shock. Can any one of my children in the comment section tell me what is the sign of shock that I am talking about? Cold, clammy extremities. Then ischemic chest discomfort. Because of the ischemia, the patient can have chest pain and acute heart failure. These are the important signs of hemodynamic instability. And if you have any of these signs of hemodynamic instability, go for cardioversion. So always remember this. If the patient is in shock, you have to shock the patient. Remember this once again. If the patient is in shock, you have to shock the patient. Right? Right. So one doubt by Dr. Irene. Sir, would we give adenosine as first line if the patient was not hypotensive? Dr. Irene, the diagnosis here is that of atrial fibrillation. Typically, the drug adenosine is given for paroxysmal supraventricular tachycardia, that is PSVT. So if the question was absent P waves with regular RR interval, then it would have been PSVT. So you have to read the question very carefully, Dr. Irene. If it was absent P wave with regular RR interval, it would have been paroxysmal supraventricular tachycardia. And if the patient is hypotensive, in this PSVT also it is shock. But PSVT with normal BP, then you are right, Dr. Irene, you have to give adenosine. Okay, right. So that is also clear. Now coming to the next question, a patient with history of rheumatic heart disease presents with shortness of breath. And on examination, the following findings are noted. There is a very hyperdynamic precordium for this patient. There is water hammer pulse, very important. Can anybody tell me in which condition do you get water hammer pulse? Also known as Corrigan pulse. You know it is seen in aortic regurgitation. Then pistol shot sound over the femoral arteries, again seen in case of aortic regurgitation. Auscultation shows a pansystolic murmur over mitral area. So you tell me in which valvular heart disease of rheumatic etiology, because already it is given rheumatic heart disease, will the patient have a pansystolic murmur over mitral area? It is going to be mitral regurgitation. And also an early diastolic murmur over aortic area, it could be the aortic regurgitation having the early diastolic murmur. What is the most likely valvular lesion is the question. So they're giving a combination. What is going to be the answer? It is going to be aortic regurgitation plus mitral regurgitation, that combination. Okay, very important. So I hope you are clear. It is a rheumatic heart disease, and I have taught you in my lectures also, when a patient has a rheumatic heart disease, can he have multiple valvular lesions in same patient? Possible. So this patient is having a rheumatic heart disease with more than one valve getting affected, causing both aortic regurgitation and mitral regurgitation. Why not option B? Because in mitral stenosis, it would have been mid-diastolic murmur. So I'm ruling out option B, option C, because I am not getting any sort of mid-diastolic murmur. And why not option D, aortic stenosis? It will have mid-systolic or ejection systolic murmur, and MS will have MDM, so that also I'm eliminating, right? Okay. Next question, a female patient presents with shortness of breath. On examination, she has a left parasternal heave and palpable liver. On auscultation, a loud pulmonary component of the second heart sound and a systolic murmur are noted. What is the most likely diagnosis? So the question is regarding a female patient with shortness of breath. So left parasternal heave, we know it is associated with what condition? Can anybody tell me out of my children in the chat box? It is suggestive of right ventricular hypertrophy, RVH, correct? And there is some sort of a palpable liver as well. The liver is palpable. So maybe there is some sort of a right heart failure causing a congestive hepatomegaly. So this could be due to a congestive hepatomegaly due to a right heart failure. Congestive hepatomegaly is what you will call it. Congestive hepatomegaly. Okay. But very important point in this question, there is a loud pulmonary component of second heart sound, which means the P2 is loud, and systolic murmur. So what do you think? Female patient, shortness of breath, loud P2, you have to consider the condition pulmonary arterial hypertension. So when there is a pulmonary arterial hypertension, you may get a loud P2. And what about the other findings? What is the reason for the right ventricular hypertrophy? I've always told you, when there is a pulmonary hypertension, there is always a chance of a right ventricular hypertrophy possible. And who is going to tell me what is the reason for the systolic murmur? Because any patient with a pulmonary hypertension, there is increased risk of developing what condition? Tricuspid regurgitation, correct or not? Patient with pulmonary arterial hypertension subsequently can result in buildup of pressure inside the right ventricle. This can cause again back pressure, and there can be a tricuspid regurgitation, correct or not? So that is why there is a systolic murmur, and subsequently there is a right heart failure, and because of this, patient is having a palpable liver as well. Okay, so I hope that is very, very clear. Okay, right. So that is it for this question. Coming to the next question. Patient presents with an episode of anginal chest pain. So again, let me tell you the topic of ischemic heart disease, very important for FMG exam, especially the management part. If you have difficulty in understanding or the long videos, please go through the revision videos at least in the app to understand about the management. All these MI management I've summarized into small short videos, so you can go through that. So ECG reveals ST segment depression in the precordial leads. What is the next best step? What do you think? So I am already eliminating option C. Why am I already eliminating option C? Because thrombolysis is done in case of ST segment elevation MI and not in case of ST depression, that is non-ST elevation MI. So here we are considering a non-ST elevation myocardial infarction. Okay, so I'm eliminating option C. And we know that the next step is not going to be any sort of a stress echocardiography. That is not the time to do that. I am eliminating that as well. Next, administer aspirin. So aspirin administration is important. But do you think anybody presenting with a non-ST elevation MI is going to be immediately discharged? No way. I'm eliminating this option as well. So my option for this particular question is administer aspirin and clopidogrel. Now you might ask me, sir, sirf aspirin clopidogrel, is it enough? What about anticoagulation? Well, it was not mentioned in the option. So always in MCQ, you have to pick up the best option. Here anticoagulation was not mentioned in the option, hence we cannot take such an option. So this is the answer for this question. Next, regarding heart blocks, I think two questions came from heart blocks. So the first one, which of the following statements is correct regarding first degree heart block? What do you think? Is it normal PR interval and prolonged RR interval, or prolonged RR and prolonged PR and normal RR? What do you think? So the answer for this question, see, in case of a first degree AV block, the PR interval is absolutely normal. Out of the different types of AV block, the only AV block or the only heart block where the PR interval is normal is the first degree AV block. Okay, so I'm already eliminating these two options because I know that the PR interval is normal. But what about the RR interval? What do you think in case of a extremely sorry. Okay, so I'm just eliminating this. Can you just tell me regarding this first degree AV block? So what is the first degree AV block? Extremely sorry, apologies for the confusion. So in case of first degree AV block, remember, there is a PR interval prolongation. Okay, so in first degree AV block, there is a constant prolongation of PR interval. In first degree AV block, there is a constant PR interval prolongation. Constant PR interval prolongation. Okay, there is a prolongation, but it will be constant. Okay, constant PR interval prolongation, which means the PR interval will be more than 200 milliseconds, right? 200 milliseconds. So the PR interval is prolonged. But what about the RR interval? The RR interval is actually normal. Okay, so there is a prolonged PR interval. So I'm eliminating these options because the PR interval is going to be prolonged, but the RR interval is going to be normal. Okay, so RR interval is going to be normal, hence the answer is option B. Okay, so I hope that is clear. Apologies for the confusion. Okay, right. So that's it. Let's go to the next question. Okay, so which of the following best describes Mobitz type 1 second degree AV block? What do you think? Which describes Mobitz type 1 second degree AV block? So there are two types of second degree AV block, Mobitz type 1 and Mobitz type 2. So what do you think? Well, in case of Mobitz type 1, the answer is going to be option B. There is going to be a gradually prolonging PR interval followed by a non-conducted P wave. That is known as Wenckebach phenomenon. Okay, Wenckebach phenomenon is the answer for this question. Okay, right. So that is clear. And normal PR interval followed by drop the beat, that is not going to be the answer. It is seen in case of Mobitz type 2. Complete AV dissociation is going to be seen in the third degree AV block, which is also known as the complete heart block. Okay, right. Let's go to the next question. I think a very simple question. What is the mechanism of the A wave? It is due to what? The right atrial contraction. Okay. And what about the other options? Fall in right atrial pressure due to atrial relaxation. Wrong. It is basically that is the X descent. That is the X descent is the reason for this. Venous return, that is the mechanism for the V wave. And fall in right atrial pressure due to rapid blood flow from RA to RV is the mechanism for Y descent. So I'm eliminating all these options. And I also want you to be thorough with this particular table that I've already shown in my lectures on the various JVP abnormalities and associated conditions. Absent A wave atrial fibrillation, giant A wave right ventricular hypertrophy, Canon A wave in case of complete heart block and junctional rhythm, prominent X descent in case of cardiac tamponade, absent X descent in case of tricuspid regurgitation, absent V wave hypovolemia, prominent V wave hypervolemia, giant V wave tricuspid regurgitation, prominent Y descent constructive pericarditis, and absent Y descent cardiac tamponade. Important points that you should be knowing, right? Okay. Next question, female patient who is a known case of mitral regurgitation presented with shortness of breath. Chest X-ray is given. What is the likely diagnosis? So what can you see here? You can see the bat wing opacities. So when you get the bat wing opacities in a patient who is having a valvular disease like MR, you are going to consider cardiogenic pulmonary edema. You are going to consider cardiogenic pulmonary edema. ARDS definitely not the answer, because MR does not predispose to ARDS. ARDS, acute respiratory distress syndrome, is also called non-cardiogenic pulmonary edema. Acute cor pulmonale is seen in case of pulmonary embolism, but this is not the clinical presentation of pulmonary embolism. Chronic cor pulmonale can be seen in conditions like COPD, interstitial lung disease, but again, we are considering here a patient with a mitral regurgitation. Answer is option B. Okay. Next, 58-year-old patient with type 2 diabetes presents with pedal edema and shortness of breath with eGFR which is reduced. It is only 45. Which of the following classes of anti-diabetic medications provides cardio-renal benefit? What do you think? Very important question. What do you think is the answer for this? It is SGLT2 inhibitors. Told you again in my class, this is a very important question. SGLT2 inhibitors are having this cardio-renal benefit. Okay, right. Smoker presented with gum bleeds, delayed wound healing and corkscrew hairs. What is the likely diagnosis? Answer, vitamin C deficiency causing scurvy. Let us learn 5 important points about scurvy. Number 1, already it is due to vitamin C deficiency. So it has corkscrew hairs. Just around the hair follicles, you will have perifollicular hemorrhages. You can also have petechia and ecchymosis. There can be impaired wound healing as well as anemia. These are some important manifestations of scurvy. Next question, chronic smoker presents with shortness of breath. Spirometry reveals FEV1 is equal to 60% of predicted, FEV1 by FVC ratio of 60. So when this ratio is less than 0.7, you are thinking about obstructive lung disease, correct or not? You are thinking about obstructive lung disease. So what do you think is the answer here? We know that ILD, again restrictive, silicosis also mainly fibrosing disease, restrictive, bronchogenic, again not the presentation. So this is basically a COPD, and you can see that the FEV1 is also reduced. Okay, so I have taught you in my lectures that patients with COPD, that is patients with obstructive airway disease having FEV1 to FVC less than 0.7, based on the predicted FEV1, you can divide it into the various gold categories 1, 2, 3, 4. If that is the case, can anybody tell me in the chat box which gold staging does this belong to? It is FEV1 60, it is gold stage 2. Okay, gold stage 2, the answer for this question is chronic obstructive pulmonary disease. Which is not a feature of Pancoast tumor? What do you think? Ptosis, meiosis, anhydrosis, all of them are features. So I'm eliminating all of them. It is not exophthalmos, it is enophthalmos. Okay, right. So I'm eliminating option D, and eliminating the other options, and the correct answer is going to be option D, that is exophthalmos. So we know that in case of the Pancoast tumor, there is a tumor in the apex of the lung which can cause local compression of the anatomical structures like the brachial plexus, especially the lower trunk, the sympathetic chain, producing the various manifestations of Pancoast tumor. Okay, right. So next question. A 32-year-old man had a physical altercation with a bouncer at a party. Sometime later, he developed sudden breathlessness followed by collapse. Okay, so there is sudden breathlessness and there is some sort of a trauma. So the patient is having some sort of a trauma and then sudden breathlessness followed by collapse. Okay, so absent breath sounds with hyperresonance on percussion over the right hemithorax. So we're thinking of a traumatic pneumothorax here, and it's a massive pneumothorax, which is why there is a tracheal deviation to the left side. So the answer is going to be option D, that is traumatic pneumothorax. It's not pneumomediastinum because the patient will be having a subcutaneous emphysema, chest pain, so that is not there. Lung collapse, again not the typical presentation. You're not going to have any sort of hyperresonance, and tracheal shift will be towards the same site in that case. Right lower lobe consolidation, that is pneumonia, again not the clinical presentation. This is typical presentation of a traumatic pneumothorax. Okay, right. Coming to the next question, a 38-year-old man is diagnosed with HIV infection and pulmonary tuberculosis. He started on anti-tubercular therapy and antiretroviral therapy. After 1 month, the patient presents with fever, malaise, and worsening of respiratory symptoms. Now, this is interesting. Normally, when you have a disease and you start treatment, you are expecting that there will be improvement of symptoms. But why do you think the patient is having worsening of symptoms after the starting of the treatment? Well, this is a special condition that is known as IRIS, Immune Reconstitution Inflammatory Syndrome. So what is IRIS? IRIS is important. I've taken this in your lectures in infections as well. So look at this. Immune Reconstitution Inflammatory Syndrome is that, suppose you are starting antiretroviral therapy in a patient. So when you are giving antiretroviral therapy, can you tell me what will happen to the immune status of the patient? Definitely there will be an improvement. So if the immune function is improving rapidly following the starting of ART, sometimes what can happen is that there can be certain systemic or local inflammatory reactions at the site or sites of pre-existing infection. Okay, so which means, suppose somebody already had a tuberculosis and there is a tuberculoma in the brain. I am starting the patient on both anti-tubercular therapy and antiretroviral therapy. Now, when I start the patient on antiretroviral therapy, the immune system actually improves and the CD4 count increases. Now, what happens is that the tuberculoma which is there in your brain, all the immune cells will go and attack the tuberculoma. And this can result in an inflammatory reaction, which sometimes can be harmful to the body. In fact, the body response is trying to protect the body, but it can be harmful. This is known as, IRIS. And this occurs in 10 to 30% of patients who are initiated on antiretroviral therapy, and usually happens within 4 to 8 weeks on starting ART. Now, because of this, what you usually do is that when you want to start antiretroviral therapy, especially in a patient who is already having an opportunistic infection, you will first start the treatment for the infection, and only after a small time gap you will start the antiretroviral therapy. For example, if the patient is having CMV retinitis, you will start the antiretroviral therapy only after 2 weeks of starting CMV treatment. Because if you start ART along with the CMV treatment, as I said, when there is a sudden increase in CD4 count, this will go and attack the eyes. So that is not good for the body. Similarly, TB meningitis after 4 weeks of starting ATT, cryptococcal meningitis after 4 to 6 weeks of antifungal treatment, toxoplasmosis after 6 weeks of treatment. In case of PCP, you first treat the PCP and then only you will be starting on antiretroviral therapy. Okay, and remember, there are two types of IRIS. One is called the unmasking iris, the other is called paradoxical iris. What is unmasking iris? Unmasking means, suppose initially the patient did not know that he was having tuberculosis. You started on ART, the immune system got activated, the immune system identified a small tuberculoma in the brain. Previously it was not diagnosed. And then it goes and triggers the inflammatory reaction. Patient develops headache, and then you evaluate, take MRI brain, okay, there is a tuberculoma in the brain. This is called unmasking iris. Paradoxical iris means you already know that the patient is having some sort of tuberculoma, already diagnosed. The first case, unmasking, we did not know that he is having a problem. Paradoxical means maybe you already know that there is some sort of a pulmonary tuberculosis. In such patients, when you start ART, instead of improvement of symptoms, there can be worsening of symptoms. Exactly what happened in our patient. He is already having this pulmonary tuberculosis, and then there is worsening of respiratory symptoms. So the condition is actually the immune reconstitution inflammatory syndrome, or the IRIS. Okay, right. Coming to the next question, a patient sustained a closed femoral shaft fracture in a road traffic accident. He develops tachypnea and hypoxemia 48 hours later. So when there is a long bone fracture and without much delay, the patient develops tachypnea and hypoxemia, what could be the cause? Is it fat embolism, cardiogenic pulmonary edema, ARDS, pneumonia? The answer is fat embolism syndrome. Another condition you should know about is the pulmonary embolism, where following a fracture, there will be a history of a patient with a prolonged immobilization. But here there is a fracture, 48 hours later there is some sort of tachypnea, hypoxemia, and some patients will even have a petechial rash. 50% of cases will have a petechial rash, but that is not mentioned in this question. So the answer for this question is going to be the fat embolism syndrome. Answer is option A, right? Okay. Coming to the next question, young female presented with binge eating followed by self-induced vomiting. What is the acid-based disturbance that is likely to be seen? So self-induced vomiting, what do you think? There is loss of hydrochloric acid. What do you think is going to be the problem in this patient? Metabolic alkalosis. Okay, metabolic alkalosis is the problem. Okay, self-induced vomiting, it is going to be metabolic alkalosis, right? And another question, again, alcoholic patient with recurrent episodes of vomiting. ABG report is shown, the pH is 7.53, the arrow is up. PaCO2 50, the arrow is up, the normal value is 40. Bicarbonate, the normal value is 24, it is 30 here. All arrows up. So pH 7.53, it is alkalosis. All arrows up, it is metabolic. So what is the answer? This is metabolic alkalosis. Okay, right. Chostek sign, simple, straightforward question. I'm not going to explain. Hypocalcemia, we've discussed this many times in the class. Twitching of the circumoral muscles on gentle tapping of the facial nerve just anterior to the ear. That is what is referred to as the Chostek sign of hypocalcemia. There was another question in the paper on hypercalcemia. The question was like this: a 65-year-old patient presented with confusion, fatigue, and polyuria. Okay, confusion, fatigue, and polyuria. And you can see that the lab evaluation shows 14 milligram per deciliter, that is the calcium value. So we know that the calcium normal value comes to around 9 to 11 milligram per deciliter. The value here is 14 milligram per deciliter. The question was, what is the initial treatment? Okay, initial treatment. So what is the initial treatment for hypercalcemia? It is IV normal saline for hydration. IV normal saline for hydration, because the patient is going to have significant fluid loss and you will have to give normal saline. Bisphosphonates, yes, definitive treatment, it is bisphosphonates, but the question what I hear from the students was regarding the initial treatment, it is IV normal saline. So remember the class notes on the treatment of hypercalcemia, you have to correct the dehydration, which is by aggressively administering normal saline, 4 liters per day, then salmon calcitonin injection, IM or subcutaneous, given 6 to 12 hours, which will decrease bone resorption and enhance renal excretion. A more potent inhibitor of bone resorption is bisphosphonates. You can give solidronate or pamidronate. Patient refractory to bisphosphonates, you can think of denosumab, which is a monoclonal antibody to the rank ligand. Okay, right. And you can see how this denosumab is acting. So you can see in the presence of any factor that stimulates bone resorption, maybe like a hyperparathyroidism, you can see that there is rank ligand here, and this can bind to the rank. But denosumab, what it does is that it will bind to the rank ligand. Okay, so thus it will inhibit osteoclast formation, activity, and survival, because normally the binding of rank ligand with the rank will stimulate osteoclast formation, survival, and activity. Okay, so in certain refractory cases like sarcoidosis, lymphoma, you can also try steroids for hypercalcemia. And cinacalcet is another drug which is an oral calcimimetic agent, which is a calcium sensing receptor agonist which inhibits the parathyroid hormone. That is another drug that can be given. Then hemodialysis using low calcium dialysate also can be considered, okay, in certain cases with renal involvement. Okay, so yeah, so the answer for this question is option A. Next question, 6-month-old. Now look at the age of the patient, 6-month-old. The patient presents with polyuria, polydipsia, muscle weakness, failure to thrive, and hypotension. Okay, so there is salt wasting, there is failure to thrive, patient is in hypotension. Laboratory findings showed hypokalemia, hypochloremia, and metabolic alkalosis. What is a likely diagnosis? So I'm already eliminating Cone syndrome. Why am I eliminating Cone syndrome? Because Cone syndrome will be having hypertension. Here the patient is having hypotension. Now, dense disease. What about dense disease? Dense disease is not going to, it's basically a problem with the proximal tubule, and the patient is not going to have metabolic alkalosis. There will be hypercalciuria, but there is no, metabolic alkalosis. But dense disease means there will be, it's a proximal tubular defect, there will be hypercalciuria. Okay. Now, between Bartter and Gitelman, what do you think? This age is favoring, infancy is more favoring what? Bartter or Gitelman? Bartter syndrome. Gitelman presentation is relatively late. Okay. So, considering all these features, that is the age of onset, there are many similarities between Bartter and Gitelman. Now, if the patient, from the recall that I got from the students, nothing was mentioned regarding hypercalciuria. So, in Bartter syndrome, hypercalciuria will be there. And in Gitelman syndrome, there will be hypomagnesemia. But students told me, no, sir, that was not there. Because if it was there, it would have been a lot easier. Because hypercalciuria means Bartter, hypomagnesemia means Gitelman. The other features, there will be overlap. But here, since the age is 6 months, it is more likely to be Bartter syndrome than Gitelman syndrome. Okay, and yes, the patient can have features of failure to thrive as well. Okay, right. So I hope that is also clear. Next, patient suffered from electrical burns. Urine sample is given for analysis. And there is a definite discoloration of urine. So what do you think? Electrical burns followed by discoloration of urine. You are thinking about myoglobinuria. It is not hemoglobinuria. It is myoglobinuria. Myoglobinuria. And this myoglobinuria occurs in the context of a rhabdomyolysis. It occurs in the context of a rhabdomyolysis. And the question is, what is the urinary finding? Urinary finding. Is it going to be RBCs? You can see a few RBCs, but that is not going to be the major finding. What about creatine kinase? We have all learned, yes, in case of rhabdomyolysis, creatine kinase is elevated. But it's in the blood or serum, blood or urine. It is in the blood. But here it is given urinary finding. So creatine kinase is elevated in the blood, not in urine. Myoglobin, absolutely right. You will have myoglobinuria. Bilirubin, again, wrong answer. So my answer is going to be option C. Okay, right. Next question, the serological status of the patient is as follows. HBsAg positive, so there is hepatitis B. Okay, IgM anti-HBC positive, what is the diagnosis? What do you think? Is it acute hepatitis B or chronic hepatitis B? Or is it recovery? Recovery means HBsAg would be negative, so I'm eliminating this option. HBsAg is positive. Vaccination means, again, HBsAg will not be positive. Here, post-vaccination, you will have what? Anti-HBsAg will be positive. But here HBsAg positive, I am eliminating these two. In both of them, HBsAg will be negative, both in recovery and vaccination. Now, is it acute hepatitis B or chronic? I can see that it is IgM anti-HBC which is positive, which means it is acute hepatitis B. Because HBsAg positive means hepatitis B. IgM anti-HBC means acute hepatitis B. But suppose if the question was IgG anti-HBC, then my answer would have been different. It would have been chronic hepatitis B. Okay, so the answer is option A. Right. A patient presents with liver cirrhosis with massive ascites. Which of the following statements is incorrect in this case? So liver cirrhosis with ascites. Mechanism of ascites is due to portal hypertension. It's a correct statement. So they are asking about incorrect statement. So I'm eliminating this. Next, serum ascites albumin gradient reflects the pressure in the hepatic sinusoids. Correct. It reflects the pressure in the hepatic sinusoids. Eliminating this. Next, incorrect statement they are asking. SAG is more than 1.5. I told you, in case of liver cirrhosis ascites, it is a high SAG ascites with an ascitic fluid protein less than 2.5. That is correct. It's not a low SAG ascites. I've told you, remember this flowchart I've taught you in the class about the causes of high SAG ascites and low SAG ascites. Even in the FMG HIT program, the high impact training program also, I have told you about the causes of high SAG ascites and low SAG. So this is high SAG with an ascitic fluid protein less than 2.5. This is something that I've taught you in my lectures. Answer is option C. Okay, right. Coming to the next question, which of the following enzymes is dependent on vitamin C? So what is the answer? This is lysyl oxidase. So, vitamin C is a cofactor for, lysyl hydroxylase, okay, is a coenzyme one second, yes, is a coenzyme for lysyl hydroxylase, which is an enzyme that is involved in post-translational modification of procollagen that is necessary for the cross-link formation. Hence, the answer is going to be option D. Okay, lysyl hydroxylase. Next, a patient presented with rash around the anus and persistent diarrhea. What is the likely nutritional deficiency? So, what do you think? Rash in the perineal region. What condition should you think about? So this is a condition that is known as acrodermatitis enteropathica, which is an autosomal recessive disorder characterized by abnormalities in the zinc absorption, okay, or abnormalities in the zinc absorption, okay, abnormalities in the zinc absorption. And the features include a rash, which is commonly seen in the perineum, the face area, and the extremities. And you can also have diarrhea, depression, alopecia, and muscle wasting. These are the clinical features. So the answer is going to be option C, that is zinc. Okay, right. Next, a group of friends ate fried rice from the canteen, developed vomiting 4 hours later. So when the incubation period is very short, less than 6 hours, there are few organisms that you will consider like Bacillus cereus, Staph aureus, but when it is fried rice, you should always think about Bacillus cereus. Fried rice, you should always think about Bacillus cereus. That means there is preformed toxin, which is why the incubation period is less. Salmonella, Shigella, you will have longer incubation period. Diarrhea will be a feature. Even Clostridium perfringens also. All the other options will have a longer incubation period. Bacillus cereus will have a shorter incubation period. Okay, and it is again fried rice is quite common with this. Okay, contamination is quite common. Okay, so that's it. We have discussed the questions of the FMGE JAN in a very concise and crisp format. Any doubts that you have got, you can just, this is my Instagram ID, dr underscore Rahul underscore Rajiv, dr underscore Rahul underscore Rajiv is my Instagram ID. Any queries you have got, you can just reach out to me. I've also got a dedicated FMG preparation WhatsApp group. In case you're not there in that group, you can just ping me in Instagram. I'll send you the link for the Instagram for the WhatsApp group for FMG preparation as well. Thank you so much everyone for joining this discussion session, and all the best for your exams as well. Thank you so much everyone. Bye-bye.